This video is on trauma, PTSD, and how to recover. My name is Dr. Greg Muller, and I'm an assistant professor and licensed psychologist living in Austin, Texas. Now, before you watch this video, please take a minute to review these disclaimers. They apply to both the content in this presentation and into future presentations that I'll make as well. I also want to give significant acknowledgement at the start of this presentation. I want to acknowledge the work of Edna Foe and colleagues for their work on developing prolonged exposure therapy, to Dr. Risick and colleagues for their work on cognitive processing therapy, and to Dr. Denise Sloan and Dr. Brian Marks and colleagues for their work developing written exposure therapy as well. I also want to offer an outline too about a lot of the content that we're going to cover in this presentation. We're going to start talking about what is stress versus trauma, the three different interventions that are primary interventions for the treatment of PTSD, some other supportive interventions if that's something that somebody might need, and then how to adapt these interventions as well. And so often when I deliver this lecture, I ask the question of the audience or of my patient, is stress bad? The reason I ask this question is that for the patients that I work with that have PTSD, they very commonly come back and say, no, stress is always bad. Stress is never a good thing. And I think it's really important to challenge that notion. I think of stress as us being tapped on the shoulder and we're being told, hey, something important's happening here. I also speak to the idea of the stress recovery adaptation loop, right? So if we want to get stronger, we go to the gym and we're lifting weights. That puts a stress on our body. And if we're successfully recovering, our body is able to adapt to that stress and we get stronger and bigger. If we want to grow our cognitive abilities, we might go to school, we stress our mind, we recover, and our mind adapts. And I often describe the difference between stress and trauma is a stressor that's so large that people can't integrate it or recover from it properly. And so in extreme cases of traumatic experiences, we talk about the diagnosis of post-traumatic stress disorder, PTSD. And as clinicians, we're screening for a common core feature set of symptoms. So intrusive re-experiencing, where the person is describing nightmares back to what happened or flashbacks. It's almost as if somebody is snapped out of the moment that they're in and they feel as if they're back in the traumatic event, as if it were reoccurring in real time. We also look for a pattern of avoidance. That's internal avoidance, avoiding feelings, sensations, thoughts related to the event, or external avoidance, people, places, activities, objects that remind them of the traumatic event. And we're going to come back to that in a minute. We're also screening for negative alterations in mood. So people describe having intense emotional overwhelm that they struggle to cope with, or they numb out and they don't feel much of anything. We also are looking for alterations in arousal and reactivity. People describe being hypervigilant, always on edge, never being able to relax, being extremely jumpy, or they crash and they're exhausted and they're not able to function very well at all. And obviously there's other symptoms or comorbidities that are common. So like a really clear example is substance use, like alcohol abuse, where the alcohol is a way to dampen these symptoms. But very often that effort, I often, when I'm talking about this, say that oftentimes the way that we try and solve our problems is the problem, right? So people with PTSD, sometimes they turn to substances as a way to cope, and that can take a life of its own and create problems. In the United States, at least, it's a projected 5% prevalence rate of PTSD. Obviously, many people have had traumatic exposure, but just because you've had a traumatic exposure does not necessarily mean that you're going to end up with a post-traumatic outcome. And obviously, in different parts of the world that might be more unstable, have less opportunities, or where there's ongoing violence or conflict, that rate of PTSD could be larger. In the United States, projected 2-to-1 ratio of PTSD for males to females. And this is taken from the US Department of Veterans Affairs. I also, when I'm talking about this presentation, I think it's important to talk about the idea of recovery trajectories. This graphic that I'm showing you isn't perfect, but I think it captures the essence of what I want to speak to. So it's really important that when you're talking about PTSD or trauma, that different people have different recovery trajectories. So in the best case scenario, we're looking at that top green line, resilient. So somebody has a traumatic experience, their functioning might dip temporarily, but then they're mostly untouched by it, untroubled by it, and they're able to maintain their overall level of functioning. That's the best case scenario. For most people, that have a traumatic exposure, they have what we would think of as an acute stress reaction where they experience PTSD-like symptoms. And then this is that second green line, where slowly over time, without necessarily needing um, intervention, a structured therapeutic intervention, they recover from the symptoms over time. They reintegrate into life, they heal, and the symptoms fade out over time. Maybe in other scenarios, people have what we think of as post-traumatic growth, where they walk away saying, I feel so much more connected to myself. I feel so much more connected to life. I'm so much more appreciative and grateful for what I've had because I've been through this challenging experience. And then those other blue lines, what my purpose of showing you those, it speaks to the idea that very often for some people, they have a traumatic event, and when they're moving towards a post-traumatic outcome, they crash and they stay crashed. These symptoms appear and they don't recover. We're going to talk about why that is. And so before we get to that, we need to talk about the idea of experiential avoidance. I describe experiential avoidance as the most important idea in all of psychology. And I'm showing you Wikipedia because I know that you'll have access to this if this is something that you want to dig into on your own. So let's take a minute and look at this. So experiential avoidance has been broadly defined as attempts to avoid thoughts, feelings, memories, physical sensations, and other internal experiences, even when doing so creates harm in the long run. So EA is maintained through negative reinforcement. This is short-term relief of discomfort through avoidance. So this goes back to what I was just saying a few minutes ago about alcohol, like alcohol abuse, right? So the way that we try and solve our problems often is the problem. The way that we try and solve our problems often is the problem. And so what experiential avoidance speaks to is the idea that we as humans, as a way of coping, often pull back, avoid, try and modify the experience that we're present with, maybe because we don't feel like we can confront it and overcome it. And so very often what we think of as mental health disorders can be thought of as disorders of avoidance. So let's walk through this. So with major depressive disorder, MDD, people describe feeling overwhelming sadness, guilt, low self-worth, and they avoid through isolation and thoughts of suicide. Suicide very often is what we might describe as an avoidance strategy, right? You talk to people that are profoundly depressed in some cases, and you ask them, do you actually want to die? And they say, no, I just don't want to be alive anymore. It speaks to the fact that if they had another option, they would take that other option to experience wellness. We see PTSD appearing again. So people live their life and they experience intrusive memories, anxiety, reminders of that bad experience, and they avoid through trauma. They avoid those reminders. So we often, what this is leaning into is the idea that PTSD we describe it as a disorder of failed recovery or a disorder of avoidance. And so challenging that avoidance is an essential feature of the recovery process. And on we can keep social phobia, panic disorder, OCD, substance use, on and on and on. Disorders that that have an element of avoidance tied to them. And so what I'm offering to my clients in treatment is the question, what does it mean to have a healthy relationship with avoidance? And as we move through this presentation, talking more about trauma and PTSD, that's the question I want you to sit with, which is what does having a healthy relationship with avoidance look like as it relates to adversive, challenging, traumatic experiences that people have had? And so now we move on to what I describe as the PTSD loop. So let's walk through this. So a traumatic event happens. It could be a sexual assault. It could be military combat exposure. It could be a natural disaster, what have you. And oftentimes there's a belief shift. And the belief shift for people is the world is more dangerous and I am less confident to confront this danger. And people, their body is very reactive to the trauma reminders. Remember those trauma symptoms that we had talked about before? And so that dotted line represents that some time goes on, the danger passes, the person returns to their daily life. But their body is still reactive to the trauma reminders, and so they bump into things, people, places, objects, activities, and it cues the trauma symptoms. The symptoms reappear, and so the person says, "Oh my God, I don't want to feel this way. What can I do to fix this? Oh, I can avoid." And the crazy thing about that is that it actually works. The avoidance works as a way, as a dial to turn down the distress associated with confronting the traumatic stimuli, the traumatic reminders. But this creates a vicious loop where the person begins to avoid reasonably safe situations. And that avoidance pattern prevents the processing, the emotional processing of the trauma memories so that the person can make sense of them. They never learn that certain situations are low risk and you can actually handle them. And these traumatic beliefs persist and the symptoms continue around and around and around and around. The clearest example of this are Vietnam vets who, after 40 years, they're saying, "This happened decades ago. Why am I still struggling with this?" And I want to pause here and say, sometimes when I talk about avoidance, people feel bad. They're like, "Oh, I'm doing the avoidance thing. Oh, this makes, this isn't good." But we all avoid, right? Like you might, as a clear example, I would imagine that most people that are listening to this wear shoes, right? Shoes are kind of an avoidance strategy. You're avoiding wanting to step on stuff and hurt your feet. Or you might have your air conditioning or your heater on in your home, right? You're avoiding extreme temperatures, right? So avoidance isn't necessarily a bad thing. But when there's necessary activities that we need to take, if there's necessary challenges that we need to confront, if there's pain that we need to move towards, avoidance can get us can get us stuck and keep us from taking that necessary action that's going to move us towards wholeness and healing. And so again, that question comes up, which is, what does having a healthy relationship avoidance look like, and how can we use different interventions to support that process? So now we're turning away from diagnostics and assessment and towards those behavioral interventions for PTSD. So there's three interventions that we're going to talk about predominantly in this lecture. So prolonged exposure, cognitive processing therapy, and ridden exposure therapy. So with prolonged exposure therapy, um, it's very heavy on the assessment, the psychoeducation. Does this person have PTSD? Are they indicated for this treatment? And it also works for them to build what we think of as a fear hierarchy or a fear ladder, a list of necessary challenges to confront the avoidance, and then completion of imaginal exposures, which is a retelling of the traumatic experience. We're going to talk more about that in a little while. Another excellent intervention is cognitive processing therapy, CPT. Both prolonged exposure, all these interventions work in very similar ways. They have similar efficacy. They just accomplish it through different means. And so cognitive processing therapy focuses more directly on the post-traumatic beliefs that people acquired. So the world is more dangerous, I am less competent, those. The beliefs are confronted in both PE, CPT, and ridden exposure therapy, but CPT very directly confronts the idea of those beliefs. And there's different skills modules. This is done kind of pen and paper to challenge those belief and thinking patterns. And then late stage CPT, excuse me, late stage CPT focuses on 5 trauma themes. I love this about CPT. So CPT, the 5 trauma themes are safety, trust, power control, and esteem and intimacy. These are the 5 trauma themes because we know that trauma disproportionately affects these 5 domains of our life. We all have a relationship to these 5 themes, and trauma can delay us from developing healthy relationships with these things or disrupt pre-existing healthy relationships with these themes. And now we also are going to talk about ridden exposure therapy. Ridden exposure therapy is a newer intervention, but I'm really excited with how it's developing and the outcomes that we're seeing from it. And this purports to resolve PTSD or improve PTSD within 5 sessions. And I'll talk about that model in a little bit as well. So we're going to start off with prolonged exposure therapy. So key notions in PE are that PTSD is the result of failed natural recovery process where people use avoidance-based coping to manage the post-traumatic distress, and that keeps them in that loop that we were talking about before. Healing, or return to wellness, is how can we give people approach-based coping strategies to help them overcome, confront the traumatic reminders and cues to gain more power over their life. I describe PE very much as the science of bravery. We're in action, we're moving towards our distress with the help of a therapist. PE is also a manualized interventions. You can do it in approximately 12 or so sessions. We talked about the in vivo and the imaginal elements. We'll look at that in a minute. And uh, and as I just mentioned, it's a 12-session treatment series. So that's important because I think a lot of times people think that, oh, that I have PTSD, this is going to be a forever treatment process. I'll be in therapy for decades. Not necessarily. If you have a good working alliance with your therapist who's well trained, you can make dramatic improvements in your trauma symptoms and your PTSD symptoms in a relatively short period of time. So this presentation comes with a lot of hope that change is available to people. Okay, so now talking about those essential elements of prolonged exposure therapy. So again, we talked about how the in vivo exposures, we're in action, we're confronting the trauma reminders, those feared situations, activity, people, and through those in vivo exposures, they teach us that oftentimes the things we're afraid of are not as dangerous as we think, and that I have the power to confront and tolerate the distress that comes from engaging in these activities. I am far more capable than I think I am. And the imaginal exposure is that retelling of the trauma memory. We're doing that to process the memory, gain a more realistic perspective on the events, and put it in the context of our broader life and the future that we're moving towards. And so a great question to ask is, who should get this PE treatment? And what we're looking for is somebody that has a very specific memory of the traumatic event, a beginning, a middle, and an end. So PE would not be as useful, in my opinion, for a patient that comes in saying like, well, if I ask them, what do you want to get treatment for? And they say my entire childhood, there's good options for treatment for that. PE might not be indicated in this case. And PE can also be done with multiple memories as well. And we can talk about that in a little bit. Okay, so one note, so this is an example of a prolonged exposure fear hierarchy. When I'm working with clients, I'm developing this in Excel alongside my patient. One note on this presentation is that you'll notice in that yellow column, so those are what we refer to as SUDS, subjective units of distress. It's similar to the pain scale that maybe people have seen. So in this case, 1 is, I don't like this, but it's not too bad. 5 is, oh, this is more challenging. 10 is, holy crap, this is really demanding. One edit to this presentation is that in prolonged exposure, it's from 0 to 100. The order of magnitude is slightly different, but it's a similar idea. So I developed this fear hierarchy to give you an example of a hypothetical patient that maybe witnessed the school shooting, right? So there's there's more easier activities like writing the words gun, shoot, violence. There's higher order activities that are more challenging, like watching a video that's talking about firearms, to looking at photos of the person that had died in the shooting, to maybe even going back to the place where the shooting that happened, assuming that that's a safe thing to do. And so you're building this list collaboratively with your patient. You're asking them, what is it that we help? Where do you notice those points of struggle in your life, and what are the activities that will move you towards healing and help you confront this memory? And then with the imaginal exposure, like I said, that's the retelling of the challenging events that people can gain mastery over the memory. And so something that I might say to the patients is settle into your seat, get comfortable. Close your eyes or soften your gaze and tell me the story of what happened. Tell the story in active tense, as if it were happening right now. Include as much detail as you can and imagine the details in your mind as clearly as you can. The reason that we're using that prompting is that those cues help make the memory feel very alive, so that people are not pulling back and not standing at a distance from the memory, but engaging with it in an appropriate way. And it's also important to note that the client is recording themselves throughout this imaginal exposure and then listening to that recording for homework. And then following the process, following the imaginal exposure, you are helping the client to process that event. So the opening statement could be something like, so what was that like for you to retell the trauma trauma memory. You're helping them process it. So you're discussing impact, you're integrating new information, you're offering curious questions to move them into that space, helping them distinguish that was then, this is now, things are different now. You're avoiding giving the patient answers, you're avoiding telling them what they quote unquote should feel or think. And I didn't say this before, but it's also important to note that after about session 4, the completion of imaginal exposures is the primary activity that you're doing in session with the patient. A lot of the early PE sessions, 1, 2, 3, 4, it's a lot of staging, education, and preparation. And then after session 4, the main event of prolonged exposure treatment series is doing the imaginal exposures. Later on in PE, so the person has started confronting their memory, they're probably noticing a little bit of symptom relief. What we as clinicians are trying to focus on are hotspots. So the clearest example of a hotspot maybe in daily life is, think of your stove, right? You probably turn on the burner. If you accidentally bump that burner, you immediately pull back, you move your away from it because it's hot and painful. The hotspots are the most distressing aspects of the trauma memory. And so they're the parts of the memory that the client wants to pull away from most immediately. And very often clients might have multiple hotspots, and so you can challenge them one at a time moving through the treatment series. So let's give an example of a hotspot to make this a little more grounded. So I use the example of military convoy that comes under attack. So the hotspots are that red section in the middle. So you're driving through the forest, your convoy comes under attack, there's explosions and gunfire, and then the hotspot is when a soldier sees their friend being targeted by enemy fire, their friend gets hit, and they're trying to save their friend and they can do nothing. And then the memory, and these are the bookends, this white section. So the first bookend is the start of the memory, the second bookend is the end of the memory. And so it follows the sequence until the convoy is out of danger. And so when we're doing hotspot work, we are bringing in the bookends and we're starting the imaginal exposure. So in later stage PE, we might start the memory when we're doing an imaginal from, okay, you're seeing your friend being targeted by enemy fire, you're watching them die, you're not able to save them. And we're doing multiple rotations of that retelling in session. And so the idea behind imaginal exposures is that there's a spectrum of engagement. So, and this is something that we as clinicians have to be attentive for. So under engagement, we often describe it as, it sounds as if the client, when they're doing their imaginal exposure, is reading from a newspaper. It's like, oh yeah, and so I noticed my friend was getting shot and I was really upset and like, oh man, this is right. They're not emotionally connecting to what happened. They're standing at a distance. They're only giving the facts. They're not talking about feelings, sensations, interpretations. And then over engagement is when the person is so connected to the memory that they're overwhelmed and they might be crying, or a really clear example of this is dissociation in session. Dissociation isn't necessarily a problem, but it's a signal to us as the clinician that maybe we need to dial back the activity and make it more digestible for the person. And so what we're trying to help our client do is move into this window of appropriate engagement. Having them be at that level of appropriate engagement is because ultimately PTSD interventions are learning interventions. How can we move them into a space of engagement where they're able to learn effectively from the activities that we're doing in session? And so if you're really interested in prolonged exposure, there's a free app. It's called the PE Coach app. This is an app that people are able to use during their own therapy sessions as a way to store the audio recordings and just have other psychoeducational resources as well. So that's for immediate download if that's something that people are interested in. So now we're moving from prolonged exposure therapy to CPT. Key notions in CPT are that, it's a short-term protocolized intervention. It's not meant to be a forever therapy. We're talking 10 to 12 sessions where we get in, we could do therapy, the patient recovers, and we're able to move them back to their life. This is specifically taken from cognitive behavioral therapy treatment paradigms. And again, it's cognitive processing therapy. It's focused more so on the thinking and the belief patterns that people acquired as a result of their traumatic exposure. And there's prior scholarships that has been done that says it can be done individually or in a group. I I do all three of these interventions in my own clinical practice. And so, again, talking about those key notions. So, what CBT talks about is that as we live our lives, we're using our senses to collect information. We're collecting information about our environment so that we can have an understanding and ultimately control our environment. And so, one of the challenging elements of people that have PTSD is that very often as children, we're taught the what we refer to as the just world belief, right? And the just world belief is that good things happen to good people, bad things happen to bad people. Now, you can imagine if you are an adult and you've retained this belief moving into adulthood, that if you have a traumatic event, this belief disrupts your world, right? Because you're like, oh my God, this bad thing happened to me. I must be a terrible person. It must be my fault. Bad things don't happen to good people. It shatters their world. And so this creates a lot of distress, confusion, dysfunction for people. And this is what part of that recovery process looks like in a CPT treatment series. So, um, so when traumatic experiences occur that result in PTSD, those experiences can either conflict with our private beliefs or support our previous beliefs. So I use the example of the sexual assault here. So let's say that first row. So let's say somebody believed, okay, so most men are trustworthy and safe. And then the trauma happened. That belief gets shattered, perhaps. And the person walks away from the event saying, all men are always dangerous. I must be hyper alert around all men. Or maybe somebody before the trauma is like, men are terrible, men are dangerous, this isn't good. And then the traumatic sexual assault occurs, and they're like, see, I knew it. This is all my fault. I should have known better. I believed this before, and that belief, I didn't listen to that belief, and now I really have to listen to that belief, right? And so it's this entrenchment that happens for people. And so the intrusive trauma symptoms occur when people are not in a healing space to process and make sense of their experiences. And it results in what we think of as a stuck point. So I think of a stuck point as like a rigid knot in our thinking that prevents our mind from moving properly, right? We're going to give examples of what stuck points look like in a minute. They prevent our, so one of the things that good therapy is trying to accomplish is moving people into a space of psychological flexibility. These post-traumatic beliefs can be thought of as stuck points because they keep us from being psychologically flexible, from responding to our experiences in adaptive ways. And so this outlines what a CPT treatment series might look like. Again, it's 12 or so sessions, about 50 to 60 minutes. Early CPT is similar to prolonged exposure in that it's a lot of good psychoeducation, goal setting, explaining. So in CPT, they call them practice assignments. They're homework, right? I think if people are interested in treatment with CPT, you have to be okay with doing a lot of writing activities. So we're giving clients, we're doing worksheets in session. They're going home and doing worksheets at home. Some people love that. Other people are like, oh my God, this feels like school. I hate it, right? If it feels like schoolwork to you, CPT might not be a good treatment for you. You might want to consider doing something else. So early CPT is a lot of setting a frame for the work that's being done. Middle CPT, you're doing a variety of activities. You're giving the client a lot of different skills to help challenge and confront the traumatic beliefs and make better sense of them. And then late stage CPT, you've developed all these skills and now you're applying the skills to those 5 trauma themes. Again, safety, trust, power control, esteem, and intimacy. You're building healthy relationships with these themes, and then you're talking about relapse prevention. And usually by late CPT, if the person has taken the work seriously, really put in the effort in session and for homework, they're starting to feel symptom relief and starting to feel like they're going back to their old life or to a new life that's even better. And so we had talked about stuck points before. So again, stuck points are rigid patterns of thinking that arise as a result of traumatic exposure that keep us stuck and prevent us from adapting to life well. So let's take a look at some. It's all my fault that the accident happened. I should have known that he would hurt me. I must be on guard at all times. I must be able to control everything that happens to me. There's no way a civilian could understand what I've been through. I must respond to all threats with significant force, right? Imagine what this does to a person. It puts them in a place of hypervigilance, of unsafety, of really not being able to make loving and safe choices for themselves very often. And so we as clinicians are helping the client to identify two types of stuck points that don't worry so much about the names. I tend to explain this as past and future related stuck points. So there's assimilated stuck points about the past. And there's often an element of guilt and blame. If only I had X, I should have done X thing, and then it would have had a different outcome. Should have, could have, would have, right? The over accommodated stuck points are more present and future oriented. And so they say things like never, always, no one. They're very commonly related to those 5 CPT themes: safety, trust, power, control, esteem, and intimacy. Again, so there's different categories of stuck points. Our goal when working with the client is to identify, to inventory what are as many stuck points as we can identify. We're sorting them into the different buckets, and then we're helping the client to attack them, to build skill and challenging them so that they resolve and shrink. Okay, so who is CBT designed to help? Do you suffer from a significant avoidance as a result of the trauma reminders? One of the goals of CBT, I think in some ways of CBT is it's a way to engage in productive grieving. So very often when people have experienced trauma, they've stuffed their feelings. They've pushed their feelings down. I'm not going to allow myself to feel that fear, that anger, that rage, that disgust, that sadness. We think of those as natural emotions. Natural emotions are emotions that just arise without us having to think about them. So maybe somebody gives you a gift and you just immediately feel happy, or if somebody were to punch you, you might get angry. The emotions that come around without thinking. And so one of the recovery trajectories in CPT is how can we help people to be present with those natural emotions? Express that fear, express that disgust, express that anger, so that it's kind of like a soda can. Another metaphor we use is that a soda can that's shook up is under pressure. We are cracking that lid. We're letting out all that tension that's been bottled up. And then also, how do we help change the way the client interprets the trauma so that they experience less manufactured emotions? So a really clear example of a manufactured emotion is shame. Manufactured emotions are emotions that rise as a result of having to think. So a visual I want to give you for manufactured emotions is to imagine a big bonfire, right? And the thinking, we're just throwing logs on the fire, we're keeping that fire going. And so by resolving the manufactured emotions, we're helping people to not have thinking patterns that are maintaining those emotional reactions. And then helping them to shrink their stuck points so that they're not leading to unworkable conclusions as a result of those stuck points. Okay, I'm not going to go through all the CPT skills in this presentation. This is outlining what some of those might look like. One of the really cool things about CPT is that it's open. I've seen it be open source, where you can find a lot of these worksheets online. You're going to want to do these worksheets with support of a therapist, but if you're just curious what they look like, this is what they're called. You'll see one of those reflected on the right here. So it's the Identifying Emotions handout that's completed in early CPT treatment. The reason we do this handout is very often people with PTSD or trauma experience emotional numbing, and this is meant to give them a cognitive framework for understanding, how do I think about what I'm feeling and how do I put words to what I'm feeling? This this emotions star talks about how we can feel neutral, and that's not necessarily a bad thing, or that there's a spectrum of emotional engagement that we might have. So a clear example of this is we might be mildly amused, or we could be ecstatic, right? There's an intensity and a range to what we're experiencing. And here's a list of more support resources for CPT. And there's a phone app that you can also download if you want to check that out as well. Okay, so now we move on to our third intervention, ridden exposure therapy, WET. This is a short-term treatment for PTSD. What this purports to do is to resolve or improve PTSD within 5 sessions. And at first, when I heard that, I'm like, there is no way that could be true. But I'm really interested in this intervention. I'm really excited by the outcomes that we're getting. And so in my own work on the D43 Ukraine project, we have some of our colleagues that are doing this work related to written exposure therapy as it relates to Ukrainian civilians and Ukrainian military personnel that have received trauma as a result of the conflict. And so I want to also point out too that it's not necessarily a new treatment. This is a modified form of imaginal exposure meant to be more faster and more tolerable. And when we say tolerable, what we mean is that it's written in past tense. So if you remember back to how I was leading the person in the imaginal exposure, I said, describe it as if it were occurring right now. Written exposure is written based on how we're looking back at the event now in past tense. And what's really cool about WET is that there's no homework. You're doing all the writing in session. You show up, you're writing continuously for 30 minutes. You offer that writing to the therapist for them to hold, and then you go home and you don't have to think about this necessarily between sessions. And so initial research has shown that WET has similar treatment outcomes compared to CPT, compared to PE, and there's also indication for WET in veteran populations as well. So you might say, so again, WET might be really good for people that are like, I love writing. I love the idea that I can make significant improvement in 5 sessions. I love the idea that there's no homework. You might be a great candidate for WET. Now, if you say, I hate writing and that's not something I enjoy doing, WET might not be a good option for you. And so this is why I myself have been trained in multiple trauma interventions. And that's why I work to train other people in different trauma interventions so that whatever client you're working with has more of a choice with what treatment might look like for them. And so in written exposure therapy, again, you're selecting similar bookends as with PE. And so you're looking for a memory that has a clear beginning, a clear middle, and an end. It doesn't have to be a perfect memory. So sometimes people might have lost consciousness during the traumatic event. That's okay. But as long as we have some type of workable memory that we can lean on. And if the memory, it's also important too that sometimes people come in and they say, well, my traumatic experience occurred over 4 days or a week or what have you. So we're helping to coach the client. How can we narrow this memory and shrink the memory down to something that's workable in sessions so that you can write about it productively in a few sessions? And it's also important that it needs to be a criterion A traumatic event. And what we mean by criterion A event is something that was like an acute threat to your safety or life or that of somebody you knew or care about, right? So like a not good event for WET would be maybe like I failed my spelling test, right? Like that it might be stressful and upsetting, not necessarily a criterion A event. And so we want to pick things that meet that criteria. Okay, so how does a typical WET session, like one session, look? So after a session has ended, you're collecting the homework. The therapist's responsibility between the appointments is to read that writing so that in the next appointment, you can coach the client on how to make their writing more specific. You're collecting the subjective units of distress. So again, it's that 0 to 100 scale. And then you're reading the writing prompt. So I'm going to show you that writing prompt in a few minutes. The primary activity in a WET session is that the client is writing continuously for 30 minutes about their traumatic memory. And if they stop early, you're coaching them to continue writing. If the story is really short, they're writing the same thing over and over and over again to promote that engagement with the memory. And then the writing ends, you're collecting the suds again. Okay, so in the beginning, you said you were at a 90. What are you at now? I'm about a 40. Okay. And then you do a brief check-in about what that writing experience was like. Again, processing similar to prolonged therapy. And then the session ends, and the therapist's goal, as I mentioned, is to read the client's writing between the appointment. The client is not keeping their writing between the sessions. WET is very structured in that you are giving them a writing prompt. There's different prompts for each of the sessions. So for your first writing, this is assuming session 1. For your first writing, I would like you to write about the traumatic event starting at the beginning. For instance, you could begin with the moment when you realized a traumatic event was about to happen. As you describe the traumatic event, it's important that you provide as many specific details as you can remember. For example, you might write about what you saw, what you heard, what you smelled. In addition to the writing, the details of the traumatic event, you should also be writing about your thoughts and feelings during the event as you remember it. For example, you might have had the thought, I'm going to die. This can't be happening. Or I'm going to be raped. And you might have been feeling terrified, frozen with fear, or angry at this other person. And so sometimes when we're doing exposure-based interventions, whether it's prolonged exposure or written exposure therapy, I give a positive example of what I'm looking for, the level of detail. So I grew up going to the ocean with my family, and so I use that as the example. So let me give you a positive example of the level of detail I'm looking for. So in prolonged exposure, I would say something like, okay, so I know I'm getting close to the beach because I see the Ferris wheel on the horizon. I see it spinning and I see the colors. I get out. I'm feeling so happy because I'm here with my family. I feel safe. I'm walking on the boardwalk and I feel the weight of my shoes pushing down on the boards, making them squeak. I hear the seagulls that are cawing in the air. I smell um, this, the smell of boardwalk food, something like that, right? I feel safe and happy. So very visceral, very engaged, very detailed approaching of the memory. And so then I coach people and say, that's what we're looking for from you in this writing activity. And so the session ends, you collect the writing as the therapist, and then your job is trying, so as the therapist between the appointments, you're trying to figure out how well did they follow the prompt? How much detail did they give? Did they include emotions? Did they provide descriptions of the traumatic event? And then you, in the next session, are coaching them more effectively. Okay, this time I want you to add more emotions. This time I want you to add these details. And as therapists, we're anticipating that usually that first writing, it's kind of like reading a newspaper. It's just the facts. I was here and this happened and it was bad and I saw this and then it was over, right? People usually in that first writing, not always, but very often are not, they don't know to go into that level of detail. So in those next sessions, we're coaching them towards that level of detail. Okay, so we're stepping away from our three interventions. We're talking about adjunctive interventions, or I'm sorry, supplemental interventions. So very often, a key symptom feature in PTSD is sleep disruption, nightmares, or what have you. If that's the case for the client that you're working with, maybe you give them cognitive behavioral therapy for insomnia or cognitive behavioral therapy for nightmares. Those could be different options. You're welcome to look at those websites at those URLs. Or if aggression, very often people talk about struggling with significant anger as a result of their traumatic experiences. I wanted to spotlight the MIRA or MERA protocol for targeting post-traumatic aggression. Okay, so now we're talking about how to adapt the intervention, moving towards dissemination and implementation. So I want to use a silly metaphor here. So somebody can be a fantastic chef, right? They cook a delicious dessert and they're so excited and they take out the dessert and they put it in front of their guest and the guest says, I'm lactose intolerant, I can't eat that, right? So it's a similar idea with these interventions, right? We can be highly skilled, highly experienced in providing these interventions, but if you're not in the right setting or you're not working with the right client, you might, you give a great intervention, but it might not achieve the outcomes that you're looking for. Context is essential. Is this the right setting? Is this the right population? Is this the right intervention for what the person is looking for? And we're trying to strike a balance between fidelity and adaptation. And so what I mean by that is I often talk about the difference between doing quote unquote perfect PE exactly by the manual, exactly by the book, or adapting it in ways that maybe the client needs, right? So one of the ways that I've commonly adapted prolonged exposure is leaning more heavily on the in vivo element, on that fear hierarchy element, or maybe not going like, so an example, when doing the imaginal exposure, let's say the person over engages and they're getting distressed, maybe we'll have the client open their eyes during the imaginal exposure, um, or talk about it in the past tense to make it a little more digestible. We're going to try and do the interventions by the protocol exactly as much as possible, but we need to be smart and use our common sense too. So there are challenges. Obviously, PTSD treatment can be really tricky, right? A PTSD is a disorder of avoidance. People that we work with PTSD are really good at avoiding. And so we as clinicians often encounter avoidant, like the persistent, significant avoidance or an unwillingness. I always tell people that we don't have to do a perfect treatment experience, but I need you to be willing. I need you to be willing to do this treatment. Or there might be cultural barriers and stigma, right? Maybe um, the PTSD or mental health isn't talked about in your culture or in your family. And so just the idea of going to therapy, just walking into the appointment can be really intimidating for people. Or if the person is still in danger or they've experienced multiple traumas, that can really complicate treatment sometimes. It's not impossible, but we need to be mindful of it. Or do they have multiple overlapping diagnoses? So somebody could be willing to engage in treatment for the PTSD, but if their substance use or their alcohol use is out of control, out of hand, they may not be able to meaningfully engage in treatment. And so we're just taking all these things into account. Um, and so how can we adapt this? I kind of spoke to that already. So common adaptations could be maybe leaning on the in vivo exposure elements a little bit more, going slower, taking more appointments, going past the 12 sessions, doing more gentle imaginal exposures, or maybe doing a mass treatment model. So like a really aggressive treatment experience could be something like doing like 3 sessions a day for 5 days in a row, right? For prolonged exposure, or maybe doing, like I know I've done intensive CPT treatment experiences where we did 10 sessions, 5 1 week, 5 the next week, and then the person graduated. So again, we can do things in different ways to support the needs of our clients that we're working with. Okay. I've given a lot of information in this lecture. I do not expect y'all to be masters of these interventions or masters of understanding all the symptom criteria. The spirit of this lecture is just because I think that for a lot of people, they can be so overwhelmed by the events that they've experienced in their life. Can be so confused by what treatment looks like. And this presentation, this lecture is meant to simplify that. So what are different take homes? PTSD results from failed natural recovery. By approaching and using different strategies, recovery is available to people. We have evidence-based interventions, really good interventions that we know work for PTSD recovery, and understanding the context of who your clients are, what are the environment that they're in is so important. We can have a great evidence-based intervention, but if we're not applying it in the right way, it will not get us the outcomes that we want. So final thoughts. This is a quote by R.H. Sin from the book Year of Letting Go. Moving on isn't about forgetting every painful thing that occurred. It's about learning to live with the memory without allowing it to dictate your life. It's a beautiful moment when you discover that you can live with some of the memories that hurt you and still experience joy. This is a process of healing. I think that this is a beautiful quote that speaks to the spirit and the intent of what we accomplish through providing these evidence-based interventions for having meaningful treatment experiences for the people that we work with. Okay, so now we're going to pivot. I wanted to do a plug. So I am helping to develop this organization. It's called the Global Trauma Recovery Network. I do work in Ukraine, um, providing evidence-based training and trauma interventions. And the goal of this organization is to take that idea and apply it in different contexts to support adults, children, and their families in overcoming trauma of war, getting them back to productive and meaningful lives, to also expand the availability of evidence-based interventions to different settings and different people. Our website is still under development, but you can access it at www.gtrn.org. So I also want to do a plug for the Trauma Recovery and Research Center. This is one of the clinics that I work at in Austin, Texas. This is a trauma and PTSD treatment center for adults 18 plus. And we offer primary services that include CPT, PE, and CBTI. And this is in collaboration with Dell Medical School. I do not speak for U Texas or Dell Med in this presentation, but we're also looking at emerging treatment approaches, and we have different studies, and I'd be happy to connect people with that if they're interested. these are my some of the references that I commonly use in these presentations. Okay, this is a longer presentation. Thank you so much for watching. Again, my name is Dr. Greg Muller. If you're interested in the content that I presented in this presentation, feel free to go to my website, gregmuller.phd.com. Please subscribe to this YouTube channel. I'm going to be releasing more content moving forward, and my clinical practice is located in Austin, Texas. Thank you so much for your time and attention, and have a great rest of your day.